Okay, I have a question about the cavitation lecture that we just heard, which was phenomenal. Thank you.
Thank you, sir.
If you're pushing out, I like to keep things at an 8th grade mental level because I find myself, I don't get into trouble. If I go above the 8th grade mentality, I get myself into trouble. So, if you're pushing out red blood cells and you're filling it up with the serum fibrinogen, where are those white blood cells and where is the tissue surrounding going to get the oxygen from if you have a lot less red blood cells in there? Because you're going to get collapse anyway of the socket, then why not just leave it the way God designed it? With a real blood clot that forms to your real bone, because that's the way God created it. And then deal with the collapse after it's healed. I don't know, just please explain to my 8th grade mentality, okay?
Well, yeah, I think your question is very interesting and also very nicely thought, because your concern is about how we get oxygen into the socket. But as we are cleaning the socket and as we are making the socket to bleed, then we are allowing the blood from the bone comes into the site anyway, right? And then the growth factors from that plasma are actually a booster for those blood cells to come out. So you have to consider that they are orchestrating the wound healing. However, you should really, in a scientific conversation, you cannot say believe me, because believe you can have in church, but you should believe me that because that you do not want to have the collapse, because the collapse is actually the problem that makes you to not have the option whenever the patient wants for a potential implant, or the collapse can be the reason for the recession on the neighboring teeth and the beginning of a gingivitis and later periodontitis and eventually the loss of them over the time. You know, nobody tells you, and I'm not the one tells you put an implant everywhere, but today I'm telling you, make sure that you do not think socket tooth extraction is just very easy peasy. It's not, it's a surgery. And it should be timely, set correctly, and no one in the world, not even me, is able to tell you I pull out the tooth in 5 minutes, which is, I'm sorry, again, that's bullshit again. Sometimes it takes you 2 hours. And you should consider that, and you should inform your patient, you should inform your team, and the more root canal treated teeth you have, the more sclerosis you have about that tooth, and the more it will be difficult to take it out, and it breaks in 100 pieces, and then you have to clean it and clean it and clean it. So do not put that 3 molars coming in 15, 20 minutes. You should require a long time, and then you have more time to really take your time to clean, because obviously the key element in treating the socket is to first making vital again. And making vital is to just take an aggressive bore, I mean not aggressive, but like a bore, not only the curette, and to really take your time to clean that part. Okay?
Another question for Dr. G. You mentioned do not use human cadaver bone. Well, what do you use then?
I use a vegan bone. And this vegan bone is actually from sea. It's algiport. And it's about to be FDA approved in a few months. But until then, I would recommend you to use a synthetic, if you should want to use, hydroxyapatite. But I personally have no problem, by the way, to use Equimatrix, which is a bovine bone. And I don't necessarily believe that it's always the problem of the bone. I think a lot of times is the problem of not cleaning the socket. So if you do not clean the socket, and you might be ending up with a misery in the healing. And I don't want to name now both bone substitute materials that you should not use, because I don't want to, damage companies. But do not use pure hydroxyapatite synthetic bones. Yes.
Question relative to a problem I think that we have here versus in Europe. Actually, probably 3 problems. But obviously, what Michael has pointed out with the water fluoridation problem is how it affects the bones. So I was wanting you to perhaps speculate on how that problem of us having water fluoridation, which is different in different communities, how that's going to affect bone healing.
To me, again?
Either one, but I mean, certainly with Sharam, if you can address that, how you think that's going to affect socket healing.
We call it in German fluorosis, right? And we call it as this is the signs of this. We just discussed that. It's just a sign of disease, and obviously having too much fluoride in your body is affecting not only the bones, as Michael was showing, but also the healing of the bone. So I wish that he wins the case, and he does everything to do that. I would even support you with the crown thing, what I just told you, because it's important. But you really should pay attention more to it. And I would like to discuss with you later how you think about this concentration in Germany and Switzerland.
And if I could just add to that, one thing I didn't discuss today is that one of the real concerns with fluoride in the bone, especially at the lower exposure levels, is a fragility. And well before you would get fluorosis, there are abundant animal studies and many epidemiological studies linking fluoride to bone fracture. Particularly in the hip fracture has been of particular concern, where you have some weakening of the cortical bone at an important site where hip fracture occurs. And there's really good data on that. There's no question that fluoride causes bone fracture, none. And as with so many things with fluoride, it's just about sort of clarifying and elucidating, like, what is the risk threshold and how does it vary based on an individual's unique susceptibilities, whether it's nutrition, genetics, or whatnot. And we've had such a fossilized approach to fluoride and health that these important questions that get to these finer questions really just haven't been asked in the past and answered. So we're left kind of scrambling to figure it out while we have mass ongoing exposures.
I don't think that anybody besides us here, so maybe you should get the microphone.
Dr. Granati, any contraindications for PRF, medical history-wise, like cancer of the blood or history of that?
Any contraindications? Yeah. People with multiple myeloma or people with chronic lymphoma that is about to become an acute phase might have a very whitish-looking PRF or blood concentrates. And in those cases, even that, what you would do would be a very good pre-detection to isolate, to find them and to send them to an internal doctor to treat. So there is no contraindication. There is no contraindication in using PRF, but sometimes people with multiple myeloma or any leukocyte deficiencies or any lymphoma or leukemia, you would have a problem to get a clot. So if you have repeatedly the same problem with the same patients, it's worse to send him to an internal doctor to check on his potential leukocyte concentration.
Going back to the fluoride question, brain toxicity, the fluoride. We've been talking about fluoride for 25 years plus in the IAOMT. With respect for brain toxicity and the fact that there's no studies on the safety factors, yet every product that we use in our practice, the OSHA or whomever comes in, you have to keep track of the SDS sheets, safety and the safety sheets. Why aren't there any for fluoride? And if anybody in the room knows any way to detox the fluoride from the brain, or is there any possibility for the pregnant women not to have it going to the child while they're developing, the developing child?
But for the safety data sheets, which I haven't reviewed in some time, I think you'll find some, you will find toxicology data from animal models. I mean, I'd have to go back and look at what they say, but you're not going to find any assurances of safety with fluoride in the brain at any level because they haven't studied that with that in mind. We know there's toxicities, correct, and they don't currently have data that would give any assurance that current exposures do not pose a threat to the brain. And that's one of the challenges they find themselves in. They know that higher levels are neurotoxic, but they don't yet have real data to give us assurance or comfort that the current exposure levels are safe. And we have data, affirmative data, linking current exposure levels to IQ loss, although certainly, there's still uncertainty that remains with that. In terms of reducing, fluoride exposure in the body, it's not a well-developed area in terms of how one might counteract fluoride toxicity. Certainly, there's some indications like calcium is going to be good for counteracting fluoride. Iodine is good for counteracting fluoride unless you get too much iodine and then it flips. And generally, fluoride, one of its mechanisms of toxicity is oxidative stress, right? And so anything that's going to sort of mitigate oxidative stress is probably going to help mitigate fluoride toxicity. So we do know through studies in the past that populations with poor nutrition, right, are more vulnerable to fluoride toxicity or lack of vitamins. And so we know that there is a definite relationship between nutrition and fluoride and susceptibility to fluoride harm. But it's not been, I don't think, well elucidated in terms of some of the specifics.
One of the ways, approaches that we use with fluoride toxicity in homeopathic and naturopathic practice, because fluoride is an halide, we will use iodoform or some kind of sodium iodate, iodine in low dose, maybe 25 milligrams a day, and we watch the urine secretion of fluorides. And then the main damage that fluoride seems to do to the brain is a microglial activation, increases clinical inflammation in the brain, which damages neurotransmitter function, and specifically damages oligodendrocytes, which lay down the myelin sheaths of the white tracts. So there's specific agents that are now available called omega-9 phospholipid plasmalogens that are actually the precursor to allow remyelination. And that helps in all the demyelinating disorders, whether it's MS, ALS, Parkinson's disorders, or even autism. Plasmalogens can help. Also using, we find higher doses of lipophilic antioxidants like ascorbyl palmitate, astaxanthine, things of that nature that get through the brain very well and help decrease inflammation in the brain. Those have all been effective long-term clinically.
Question? Sorry. For Dr. Gennady, are you doing any histology post grafting? So to look at, for instance, if you're using equine graft versus something else, what kind of bone you're forming in those sites?
Do I do that, or do I think it's okay to do that?
Have you done it? I mean, do you have any histology on?
Do I? So the question is, am I okay with people pre-test that with whether they are good or bad to this product reacting?
Well, I guess we're both periodontists sitting back here.
Yeah, the answer is yes. If the patient is asking for even kinesiological things.
The question has to do with, because you were mentioning you've done pathology, right? I mean, reading histological slides. Have you done any histology post-socket grafting? Like after you've placed socket material, grafted the area, and then you're getting ready to go back in to do an implant. sampling that bone to take a look at what type of bone? Do you
Yeah.
have scarred bone? Do you have lamellar bone? What kind
Yeah,
of
yeah,
bone?
we
do you
have
in the area?
actually clinical studies running, and I was not able to show that today, everything, but based on in every clinical study, and there are about 25, we are taking biopsies prior to implantation, and we are testing that.
Okay.
So this is going to be a whole topic about the analysis on the micro and the microstructure of the bone. And
I'd like
indeed,
to-
we see sometimes, for example, Michael, sometimes we have a huge inflammatory reaction, or even in a prolonged time in a relatively healthy bone. So this could be some answers of potential allergy, but I think at the moment there are, in Germany at least, maybe in US too, there are institutes that would allow to test the quality of the bone for that patient in any way. So whenever the patient asks me for that, I would definitely support and give them a portion so they can do that. If they, just to make sure that we are on the same page with the patient. And
I want to thank you all for bringing your information. It's an excellent day of learning. My question is on the hyperbaric, and really a lot of information in just a short time. And
Yes, sorry.
And clarifying between hyperbaric ambient air versus oxygen, it seemed that the ambient air was quite efficient for helping with many things. Then the oxygen came in and kind of blurred has it shown that one is better than the other in certain cases or all cases? Or, and of course there's the consideration of bringing oxygen in also brings in some more caution in use. If you could comment on that.
Well, it definitely brings in some caution. And I was talking about this earlier with someone. If you Google harsh oxygen toxicity, you're going to get a paper we published 3 months ago on oxygen toxicity. The dogma in hyperbaric medicine was that from the US Navy work during the 40s with all those young recruits that they exposed to high levels of oxygen was that you cannot get oxygen toxicity at less than 2 atmospheres of pure oxygen. So I can put you in a chamber, 2 atmospheres, and leave you there hours, days, and you would not get toxic. And nobody had figured it out, but it was very likely due to the suppressive effects of the pressure on pro-inflammatory genes. And so when we started looking at this in neurological applications, we started at 1.5 atmospheres based on work that the Germans had done and others. We thought we were safe. And lo and behold, patients started cropping up with oxygen toxicity symptoms. Now, they weren't normals. They were all neurologically impaired patients. But I couldn't understand it. But they were the same symptoms described for acute oxygen toxicity. And started publishing it, presenting it, and people thought I was crazy. And now it's a certainty, and it's obvious. And so what it did was dispel this dogma. But the answer is that yes, there is benefit in these lower pressures and with pressurized air. It's just that the research has not been done comparatively until these mistakes were made with the DOD studies and the cerebral palsy studies. And so now what it is appearing, at least in chronic neurological conditions, is that these low pressures with pressurized air and a little bit of oxygen, in fact, are having equivalent benefit, even superior to some of the high oxygen dosing.
Hello, a question for Dr. Gatti. I think most of the big problems of cavitation is that the dentist cannot see, or there is different opinions about how many cavitations has a patient when we look the cone beam. I saw your slides and you have like different colors when you see the cavitation. That is something about the software?
Well, I developed that software.
Oh.
It's a patented technology to take a CBCT and make, after reviewing that through another different number of invented technologies and software, to make a 3-dimensional visualization, which is an objective, and where somebody like him would never come to me and tell me, what are you talking about?
And the other one is, what do you think about Cavitat that is going to come next
Yeah,
year?
I like Cavital a lot, and I think it's a brilliant idea, and it's working. In obviously, it's in very, very sophisticated technology. The problem, which I think, or the good thing about between me and the Cavital is, I do not only focus on the cavitations. I use that as an also peri-implantology tool to position the ideal, or to define the ideal position for the implant. And my objective today, and it was not a joke, by the way, I really would like to have an objective tool that is not too much of subjective. However, I do believe that, of course, Cavital is a non-X-ray based technology. And of course, you can use it multiple times for the same patients without putting obviously it's ultrasound based, but it might be difficult to have the whole scan, obviously, and to have it in an objective way that you can talk to the patients and say, not only cavitations, but you have here and that so many root canal treated teeth, and some of them have osteolysis on their apical, or, it's difficult to make an objective finding out of that. But it's a very profound and accepted and, a good technology. Yeah.
Hi, this is for Michael. Mercury dental amalgam was grandfathered in 1976 under generally recognized as safe. So here's another enormous global problem. But if you just look at the United States, we have over 160 million people with mercury sitting in their teeth. So there was never any safety and efficacy on this known neurotoxin. And how do we unravel all of these years of non-disclosure to basically the entire public population in this country?
It's a very good question, and I wish I had an answer. Unfortunately, we couldn't use TSCA citizen petition avenue for dental amalgams because it comes within the jurisdiction of the FDA. And I wish we could, though, because then you would have that opportunity for an independent forum to really vet the science. Problem you're going to find if you're going to challenge the FDA through some litigation is you're going to get back to that very deferential standard that I talked about earlier, and it's very difficult to win in that landscape because it's all tilted against you. So, I mean, it's not to say it's not. I suspect that, I don't know, and I don't know how much this has already been tried. It probably has. I'm speaking to people who know more about this than I do, is, citizen petitions to the FDA requesting some action and then challenging them in court if they don't rule in the right way. But I just think expectation-wise, it's a difficult case. Yes, I would love to be able to find some legal hook. So anyone out there who has a legal hook for taking on dental amalgams, I'm all ears. Okay, so.
This is for Dr. Hirsch on hyperbaric. Does hyperbaric chambers have any influence on high blood platelet levels?
On what?
High blood platelet levels.
High blood platelet levels. No, not that I know of. Could I ask a question of the panel? I'm obviously not a dentist. What is the concentration of fluoride in toothpaste? And by using toothpaste twice a day, fluoridated toothpaste, are we getting absorption of fluoride that exceeds the EPA level for, 2 liters of water a day? And
The concentration in toothpaste for kids, okay, is typically around 1,100 parts per million, okay? For adults, it's typically 1,500 parts per million, so 1.5 milligrams per gram of paste, okay? Kids, I'm actually about to, by the way, have some cases on this, but one of the real problems we have today is that they market toothpaste kids with very high levels of fluoride. They package it in cartoons like Paw Patrol, okay? And they use candy flavors, bubblegum, watermelon, right? Most parents think of this as a completely innocuous, like it's a cartoon with bubblegum flavor, right? So, and we know that kids under the age of 6, particularly, have a very poorly developed swallowing reflex. So whatever they put in their mouth, they're swallowing a lot, right? And a little known fact is that for children under 3, the CDC, the ADA, and the American Academy of Pediatric Dentistry now recommend that you use no more than a rice grain amount of toothpaste on your brush. A rice grain, it's like a little smear, right? Now, when's the last time you've seen a toothpaste commercial that advertises the paste with a little microscopic smear? They're not doing that. They're advertising that this is food, it's candy. So to answer your question, we do have a problem in this country, particularly for the kids, swallowing too much. Thankfully, as adults, we don't swallow as much, but there is some absorption through the gums, but it's not gonna be like what the kids get when the kids are just swallowing it directly. And we do know that kids can swallow more fluoride from toothpaste alone than the reference dose. That's undisputed. Yes, the FDA requires a poison warning on every fluoride toothpaste. If you swallow more than used for brushing, contact a poison control center immediately, right? And so you gotta ask yourself, why are we allowing these companies to target kids, 2-year-olds and 3-year-olds, with something that the FDA concedes is poisonous, in candy flavoring with cartoon packaging? Like, what parent is gonna look at that and think, this is a really dangerous product for my kid, I shouldn't put it in his mouth? And so that's like a real problem that we've had for a long time. And without saying too much, I am gonna take that on legally this fall.
Thank you, all the presenters. I mean, it was a great experience. I'm full of, I don't know, mixed emotions. Like, I'm emotional, I'm excited, I'm angry, I'm everything right now. And thank you, Dr. Bhattacharya and Dr. Ladapa, for a great presentation. We heard during the pandemic, like, scientists were like presenting these data and then being fired or just being silenced, or all these things were happening. I mean, you got threats. I mean, who are these people threatening you? Who are these people?
I mean, I think there's a mix of people. A lot of the death threats I got were from just regular people that were scared. So I don't even, like, for me, that's not, I don't really blame them. Like, fundamentally, the responsibility in my mind goes to the scientific experts at the very top of the scientific bureaucracies in this country, and actually also in the UK and abroad, that designed and pushed through an authoritarian response to the pandemic, with the central dogma that we are all biohazards primarily, and we should treat each other as biohazards. Right? That unchecked power is really the root cause, in my mind. And so what we need is a reform of public health that has transparency in decision making, inclusion of many, many voices outside of just this narrow range of expertise that they currently have, and then checks and balances to their power. And that's going to take a political reform of the scientific agencies of this country and of the world.
Because these are like people who are like in their labs doing researches or whatever, and not seeing clinically what exactly is happening, and not understanding the data which is coming from all these places. So, I mean, that response, in my opinion, was like, are they even authorized to make these decisions?
I mean, there was intentional desire to exclude expertise, right? In order to say anything, you have to have, you know, a lot of expertise in epidemiology or in infectious disease or in immunology or something. And then if you have expertise in those fields, disagree with Francis Collins or Tony Fauci, you get a devastating takedown. So it was essentially a usurpation of the levers of scientific power used on society at large. And it made, and anyone who had any of the real expertise, if it didn't match what they want, what they, meaning like the top scientific bureaucrats wanted said, you were going to get censored or worse, especially if you're effective. I mean, it was a tremendous abuse of power, and it led to tremendous damage to your patients, damage to you, and damage to the poorest people of the world.
So I've got a few questions. I'll start with Dr.
Pardon me.
Ladapo. And
I have one thing to add to that. It's more than just scientists. It's actually, it is a political front. Because I had a personal experience where I signed the Great Barrington Resolution, and then the day after, I put it on Twitter. I just put a link to it, to Twitter, to show other people about it. I didn't say yay or nay, whether it was good or bad. The very next day, I received a notice that I was permanently banned from Twitter for doing that. They didn't give me an explanation, anything, and I've tried several times to get back on. They say no. And it turns out, I think it was 13 days after Biden took office, that he coordinated with all of the triple letter agencies to intentionally suppress any disinformation or misinformation or malinformation about COVID. And it was a direct initiative from our government, suppressing all of us and all dissent, whether it's scientists, the general public, everybody. So it is a political ploy from the globalists, essentially.
Okay, so one question. Dr. Gennady, a quick comment on patients who have not actively on like bisphosphonate therapy, but let's say they're 5 years out or 10 years out, what you've seen in terms of the bone healing in those sites, regardless, well, in your case, using the guided open wound healing, those are, I'm assuming in Europe, they're just as pervasive as they are here in the States. So we see a lot of patients who have been on those drugs for a short amount of time, long amount of time. So if you'd comment on that.
Yeah, that's a very excellent question. And we are addressing that actually since more than 3 years. We have clinical studies, and there are also published data in PubMed showing that after socket or after, let's say, after tooth extraction, even in those patient collective, you can cover with PRF on a bone substitute material, and it heals very easily, because the problem of the patients with these drugs is actually that they have a deficiency at one point in the keratinized growth factor. That means they are not very much able to heal. And the more flaps you generate or develop, the more you will harm their ability to heal the soft tissue. However, even today in Germany, still the guidelines are saying close everything as fast and as tight as you can. And now it's one of my fights, although I'm not a lawyer, to convince them that they are wrong. So we are performing studies on showing that they can be more, let's say, not that aggressive. Because the problem is the moment that you open the ridge and you elevate a flap, you are changing the anatomy of the whole entire region. Not only you change the person's meridians and everything, but you are technically losing his vestibule and the floor of mouth. And each time he's talking, drinking, or chewing or something, he's moving on that. Because on the same guidelines where they say close, they say if there's dehiscence, do nothing, wait until it closes itself. So why do you close in the primary first? It's a debate between the old traditional surgeons and innovative surgeons. And it's as the same way he was describing. Some of those people are sitting on these chairs for decades. They don't want to make it free. And it's hard to fight with them unless you are an authority, and I am in my position as such a one. And so I try to show them in the same language that we need to change, and we will get there, because obviously the only thing that convinces is science, and science is by clinical studies which are randomized and not just few cases. So in about some months or some years, actually this year, maybe at the beginning of this year, we will have the first paper showing that they are healing not worse than the others. But as you are talking about, and to make it short, these patients need a very specific care of us, and they require a very sensitive treatment. And that means even in those patients, we need to remove the necrotic bone, and specifically after extraction, even in prevention, because if we do not that, and even if we close that, as they are getting the drugs for their therapy, which they are needed again to survive, they will develop severe and more severe osteonecrosis. And the cases I've shown are unfortunately some of them cases that were just regular persons like you and me, had developed something, and then the dental treating person did not take care about this specific thing. But I do not think that in these days we need to do a drug holiday. So we can keep on treating them, because the medical treatment is very important. We should not stop that for the dental treatment and then screw the patient by building flap, which undergoing a wound healing disorder anyway. Okay?
Thank you so much to the panel. All of you have such brilliant minds and very inspiring. My question is to Dr. Gennady regarding, and maybe I missed this slide, but third molar, like wisdom tooth, like so many people had wisdom teeth extracted. And we're dealing with looking at these cone scans, and you see all these different sizes of cavitations that are presenting. And determining between a healthy or unhealthy site, and basically the most important clinical findings, I guess, aside from looking at, obviously a medical history or symptoms, how do we really look at these sites and determine should we go in or should we not go in?
I'm really thankful for that question, and I'm sorry that I didn't mention it myself in the lecture. We just had a board, I was invited yesterday to some of the group meetings of the officials of IAOMT, and we discussed that item, and we are now addressing that in performing a clinical study again, with and without, to see where the cavitations come, and then to test them to what extent they are or they are not, let's say, toxic or infectious or any, let's say, accompanied with diseases. Because what you said is actually the case. Today, as you remember the whole time, I'm just saying cavitation. And cavitation is in Wikipedia or in Google, nothing else but the kind of empty room within bone, right? I didn't say F-talk, I didn't say Nico, I didn't say nothing like that. Because I first want to show they are there. And as we are, and my motivation is to say, let's prevent them first. And in the treatment, we are now identifying actually tools also with IAOMT to say, when do we have to remove them? When do we have to let them? Because even there are people who have wisdom teeth and they still have cavitation and dorsal of them, right? And those patients and others do not necessarily need to have to undergo a surgery. However, this is a process that I think it's going to take a couple more years, and I'm happy to deliver data as they are there with time. If we agree about that we can prevent them, then the next step would be how to treat them, and the next step would be how to identify whether they are good or bad. And by having an objective tool like this, I'm trying to show, and actually, as you have realized, I did not say diagnostic, it's just a visualization. Because at the end of the day, the patient's harm and the patient's need and your decision are the key factors making this operation to be done or not. Because just because of they have cavitations doesn't mean that you have to operate it.
Could it be a possibility to test the site by using something equivalent to like an X-tip and going into there and trying to biopsy?
Yeah, we discussed that yesterday too. The problem, yes. could be, and we will be investigating that. But in some of the cases, you don't have a liquid like we were thinking, because you just have a liquid when you go with the burn and clean it, right? Then the fatty thingy comes out. But we need to find out a technology that we go in and get something, even maybe we have to bring a medium inside. And we were discussing yesterday that there are specific labs, obviously no more in US, but in Germany, which are specialized in RNA and DNA and RNA analysis. So it's going to be one of the topics that we are trying now to initiate research with IAOMT on that.
Hi, thank you. Regarding the X-tip, have you ever thought of using the X-tip and fumigating those areas with ozone gas?
Yeah, I do believe that ozone is a very, very intelligent and very, very sophisticated treatment modality to clean things. But my purpose, and specifically the purpose of this presentation, was that nothing else but bone is able to fill that gap. And it's not possible to use ozone, to use PRF, to use whatever, to just go and think the bone comes back itself. You have to clean it, you have to bring a scaffold, and along that bone will grow. And it's going to be a topic of the next years of research to understand which scaffold type, synthetic, non-synthetic, bovine, whatever. And then the next step would be, do we have to treat them at all? And then the next step would be whether we can use the X-tip as an identifying tool to decide to make a treating path, treatment, yes or not, and if yes, how? That would be maybe an option. But I don't believe, and if you use ozone and bring it in, which is possible with the X-tip, then you cannot use the content to bring it to the lab, because then the whole things that the whole cytokines are no more viable than in that moment. Yeah.
The reason why I asked that is because I've had several patients who had trauma, and I'd done a full mouth reconstruction. They'd had many teeth in the posterior avulsed, and I went ahead and I used the X-tip as well as other extraction cases after curetting and cleaning with my round burr like you do. And then I put the ozone with the fumigation in there, and the surgeons that came behind me said they'd never felt bone so hard in their entire lives.
Yeah, I would say that the surgeon had no idea about the volumetric changes of the socket, because eventually the collapse of the socket will let you appear to have a hard cortical bone. And at this very moment of this discussion and this conference, I don't have nothing against any strategy. I'm willing to sit on a table with all the experts and make a plan and find a way that is the best for the patient. So I'm willing to learn also about it, and I'm willing to contribute my knowledge, but at the same time, I'm expecting the openness of all of other people to understand me.
Hi, this question is also for you. I do a lot of CBCTs in my office, and I send them out for reports, radiology reports like beam readers and implant concierge. And not one time have they told me, oh, there's a cavitation here. So, and I've done 200 already.
They don't see that, right?
Yeah, so.
Yeah, because they're blind.
Yeah, but my question to you is, you showed us your software, but how do we get access to it? How much does it cost?
First, you have to come to the Maxi residency at Tufts.
It's a what?
You have to come first to be taught at Tufts. I see you in January. Did you sign in already? And then I would teach you and show you the concept of everything, what I think is important for everybody to have a standard treatment. And then I open that for your CBCTs.
So the only way is to do the course. You don't do beam readers or implant concierge. You don't have that service.
No, the thing is, the problem is I could technically provide that tomorrow to everyone and make a lot of money. But the problem is, if everyone uses that, and everyone uses that the way they think, and then it's going to be gone, and people like him are waiting for that. You know what I mean? And because of that, they made it on purpose that we're sitting here. And Tell me more. Yeah. And I really want to make sure that I really want to take care that, and this is my contribution, by the way, to IAOMT, and we discussed that. I can be the one that teaches surgery because I do consider myself as a surgeon. But I want also the people to understand, and I don't necessarily mean you, and it's nothing against you as you, but the general people, because we have here people in different levels, right? These 1,400 members of IAOMT are of different levels. And we could bring them on the same level from the toxicology of the body, but the same thing, we should focus on those who wants to learn surgery or to getting more involved in surgery, to have at least a line, because this is where also IAOMT could be the standing alone, institution or actually association in the entire world taking care, because all of you, and I really need to repeat that and say that, I'm happy to be here because I know you understand what I'm talking. If I give a lecture on a conventional dentistry conference, I think I talk to the walls. So it's a great pleasure to learn also from you, but my concern today is first to show it's possible, and then to find out what needs to be treated, and then to define actually ways how to treat things. So and what you just said, it's the poor ignorance or the ignorance of those people not wanting to see that. But this paper that's coming, it's actually coming out in 4 weeks, will be changing the understanding of socket. Because the knowledge we have from the socket is, like he said, something about 1976 or something, comparable to 1942 with this fluoride. Nobody wants to change that because nobody thinks, why should I change that? So it's a big issue to change that, but it's going to be possible. So I'm happy to see and talk to you again.
Thank you.
Yeah.
There's time for just one more question. Sorry, guys.
Question about hyperbarics. Do you see that there will be a place in the dental office after surgery for hyperbaric therapy to speed up the healing of our bone growth in the mouth and to cut infections? And if so, how soon after surgery?
Absolutely, and thank you for asking that, because I was sitting here just biding my time and was going to suggest this to Dr. Gennady. In bone implant animal models, and in head and neck radiation models and so on, Scandinavians have done a bunch of work with this, and in bone core sampling models in rabbit femurs, what they've shown is hyperbaric oxygen stimulates new bone formation, such that, yes, this could be used in conjunction with it. And it's part of the use of it in irradiated tissue, which is 40% of hyperbaric medicine in the United States, done in the hospital settings, the outpatient wound care centers, is stimulation of irradiated tissue after tooth extraction, or in conjunction with irradiated fields that are undergoing reconstruction. So mandibular resection and then reconstruction, and or flap surgery and so on. But the ideal time to do it is immediately afterwards. And part of the way it's working is by reducing edema. And we didn't get a chance to get into it, but this works by an osmotic effect. The oxygen that you dissolve in plasma acts like a solute because it's not metabolized by red blood cells. And the white blood cells are in a ratio of 1 to 1,000, such that by the time it reaches the microcirculation, you've essentially got an osmotic gradient with the blood. And by osmosis, you're able to reduce extracellular edema. And this has now been shown essentially in all sorts of acute injury models with edema, brain, soft tissue, and different places in the body. So if you want to use it, and it should be beneficial, it can speed healing. Remember all those diagnoses I put up there. They are wounding and inflammatory conditions that have been historically used for it. So yes, there's a place for it. Right afterwards. Oh, yes, within, because you're also, we didn't get to talk about it, but the most powerful inhibitor of white blood cell mediated reperfusion injury is a single hyperbaric treatment within 90 minutes of reperfusion and or before the actual traumatic event. This has now been shown in carbon monoxide poisoning. It is the basis for it in brain decompression illness, which none of us knew. We weren't treating bubbles in the brain all these years. We are treating the acute reperfusion injury.
Can it be?
And that's part of what the trauma reaction is, or I should say tissue reaction with any acute trauma such as surgery. Pardon me? Ideally, if you can do it right before, that helps. But if you can do it right afterwards, and especially concentrate it, we usually do it twice a day in the first day through 5 days afterwards, and you get the maximum benefit for it.
So do you see it can be applied locally to
No.
the region?
You've got to have total body enclosure.
So that means in a head and neck cancer surgeon patient, if they are connected to the whole instruments or something, it still can be done, or should it be after the healing phase?
That's a great question. Because remember the lead-off issue of the Journal of Cardiovascular Research that I mentioned? That was done and based on what they were doing, which was operating under pressure. So operations in a hyperbaric chamber. And there's quite a bit of experience with that from back in those days. Not so much anymore since we have bypass and so on. But yes, if you could operate under pressure, ideally, you've got a maximally oxygenated field. You've also got vasoconstriction, so it's going to minimize your bleeding.
Yes, very excellent.
But you usually don't have a chance to do that, so it's afterwards.
I'm afraid it's time to end the speakers forum. I want to thank the
Pardon me?
speakers again.
I have one thing to add.
Okay.
I've been in situations where I've clinically presented with patients who had severe osteomyelitis with osteonecrosis. There's not all situations in which the patient will find HBO acceptable because they have severe claustrophobia or they don't have it available to them. One of the things I found that's effective in those cases is low-dose intravenous hydrogen peroxide. Because when you give hydrogen peroxide intravenously, you have an enzyme called catalase, which cleaves it into oxygen and water in your bloodstream. And you can get up to 12 atmospheres of oxygen in your system. And I've seen that to be extremely effective in treating these patients because it not only destroys the infection, whether it's anaerobic or aerobic, but does also rapidly help increase bone growth. It's pretty amazing stuff. And that's easy to use because it's just a half an hour IV. And I can teach you how to do it.
Okay, thank you all for being here. Let's give them one more round of applause.